So I remember I was talking to the head of economics in Italy around healthcare. And it's a beautiful building, what you'd expect in Italy, right? The Great Walls and all that kind of stuff. And I'm sitting there talking to him. I was like, what's your main problem with healthcare? And he came back to me and said, people are just living too long. We really can't afford that. And it's true, right? So if you look at the way a lot of the economics are set up, is that the number of people that are working are supporting the number of people that aren't working. Well, people are retiring, and they're living longer and not necessarily healthy, right? So think of Alzheimer's and some of the diseases that come in later in life and how expensive that is. So if you look at just the US alone, right, we have one of the highest spends in healthcare, but yet I think we're 37th in the world in outcomes. What a disparity, right? And all the world is sort of working through this. So it is certainly a global problem, which means something has to change, right? Something's got to break somewhere, and there's got to be a different method in order to do this to service the people. So if you look at the old world, right, it's all about the physician. It's relying on subject matter experts. Payments are largely based on fee for service. We're a great economy that really deals with acute care, right? You're sick, you go in, you get taken care of, you get shoved out, and you hope you never come back in. So in the new world, though, and what is starting to shift is that it's becoming patient-centric. So I talked to a few people around here, and one of the things that you'll start to see is, how do we classify somebody? You know, if you look at the traditional way, you may be somebody, for example, with diabetes. So you're a person with diabetes, but you're probably not just a person with diabetes. You're probably a person with diabetes and high blood pressure and COPD and whatever the hell you have that's associated with it. And we don't always think of the person that way, right? And even our healthcare system takes care of it in channels, right? It's not an integrated system as of yet. So that's one of the changes you're starting to see. Technology is really coming in. So some of you may see, even for your own health systems today, I know I got a patient portal, that I can go in and now get healthcare delivered over telemedicine. And I live in the backwoods of Pennsylvania. If they can have it there, they can have a lot of other places. So you're starting to see changes there, and payment systems are starting to change now based on outcomes. I talk about bundled payments and other things, so that hospitals now get a payment for a set of conditions. If you go in for a knee replacement, or if you have a stroke or a heart attack, they pay for the whole service X number of dollars, which is finally starting to give incentive to hospitals to be cost effective. Because the better they're able to service you and the lower cost and not have you come back in, the better they're able to work through that. So this is actually an old picture. It's worse than this. This is from 2014 of an example of what's going on in digital health. Everybody's trying everything, right? It's shots on goals. Maybe somebody will do it. Venture capitalists are having a field day. There's everybody doing all sorts of stuff. But at some point, we have to make some sort of systematic pulling things together. So I've talked to a lot, and I do a lot of work in emerging markets, and I spent some time talking to the Gates Foundation. And the one thing that they said is that they're very, very frustrated in the amount of money they're putting into healthcare because everybody's piloting everything, right? And they can't get past pilots to scalability, and that's actually going to become an issue. So at some point, we got to start to shift from pilots to actually scalable solutions that cut across, because that's the only way you're going to get the delivery mechanisms changed. So what are some of the shifts in technology? I think a lot of people had talked about this. So you can look at data analytics, right? We talk a lot about that. Big data, world evidence. The thing, though, with that we'll have to talk about is, yes, there are data analytics, but how do we get access to the data? Who owns your personal health information? Is it you? Is it the hospital? Is it your physician? How can you actually work through that and determine, do you want to give it to science? So there's a lot with that data analytics that's behind the scenes. You can talk about software infrastructure. So a lot of people say, oh, let's coordinate with the EMRs, that's your electronic medical record. They were developed to really be claim processing systems, and they're struggling to kind of work into the next component of that, of really taking care of your health. So they're really all about money. What a surprise. You have clinical decision supports, algorithms that do that, but then you also run into an issue when you have algorithms on clinical decision support. Do they start to fall into regulations of a software medical device? For those of you that maybe are in that, there's a whole thing going on with that with the last couple of years. Regulations on, are they actually doing things to help you make decisions about your health? You have mobile health. Everybody's got their mobile devices, Fitbits on there, everything you can think about. I've been playing a lot with devices. I think somebody said they had a Fitbit. I have one of the Apple Watches. I think I've tried them all to really figure out what do you do with them and how to use them in a way that's very different, plus everything now hooks to your phone. So people, again, trying to figure out how do you carry your health concerns with you as you work through the daily life. And then the big one now that's really starting to come in is cybersecurity and data privacy. Data privacy was always there. So if you think about some of the terms of HIPAA, some of the data privacy laws that came from Europe, a lot of things came into that, but now comes cybersecurity. How do you actually protect the things that are going on? And I just recently heard one which actually scared me quite a bit. It was talking about medical devices and how do we protect those from attack? So if you have a medical device that maybe monitors and gives out things for pain control, what if somebody breaks into that and does something with it? What if somebody breaks into things that you have that's monitoring your heart? I'm like, I never really thought about it. Oh my goodness, that's a whole nother category. So when you want to produce value in this space, what are some of the things that you want to consider? So I talked about security, privacy, and threats. This is going to be, I think, in my mind, a really big area. So it's already been huge in the financial industry. I think the healthcare industry is just trying to figure it out. So everybody thought, well, if I just keep my data, I'm fine. But the way to really make a difference in healthcare is to share it across all the different areas. How are we going to work that through? You have trustworthy data. I'll go into each of these. What's the data? There's more data out there than we can possibly deal with, but is it trustworthy? Standards, are they open or not? The problem is when you have so many standards, you don't have any standards, and they keep changing. So for example, I know that there's some laws that are coming out with the FDA, and they've set some standards on software medical device and then continue to change them every 6 months. So not quite the definition of my world of a standard. The healthcare delivery model, what's going to change in that particular space? And there's a global concern. So let's talk a little bit about these. So regulations are increasing, and it's not going to go away, right? Everybody knows HIPAA. You have application security. What's going on with medical device? What is a medical device? Even if you think of something like a tongue depressor, believe it or not, that's a class 1 medical device, and you have to register it and do all that stuff with it. You have privacy. I talked about cybersecurity, which I think this is a new one, at least it is for me, that's really kind of coming into that space that I never really thought about. And terrorism, and how does that play into software medical devices? We'll see. And then there's another thing called consent management, which is something we're looking at pretty closely. So all of us are pretty used to consent of some point. You go onto a website, you say yes, fine, whatever. You usually don't read it all that carefully. But there's going to be something around healthcare where you're going to be asked about consent. So usually you consent the information into the application to allow your physician or your doctor to use it in order to help you. What's going to start to come out is, do you consent your data in a de-identified way to be then put towards research, right? And I think that's going to be the next way that's going to happen, and that's what's going to allow you to feed into big data. Because without that, you're not going to get the data sets long enough to make big enough to get the insights that you're going to need. So I kind of said trustworthy data. Everybody's an expert. Right? So there was the boring sites, and I'll call them boring sites now, as WebMD, and I think people go to them if they have to. But I know if you're on a new medication or if you've been diagnosed with something, what do you usually do? You go in, you do a Google site, you come up with some blog site that looks okay, and everybody is now reporting on what's going on with them with that particular drug. How trustworthy is that? Right? Are they making self-diagnosis? Are they really understanding the cause and effect of science, and how are people then using that to go forward and really understand their disease classification? Some may be very valid, some may not, but how do you know what to trust? Devices. I recently heard that for the first time, device sales are going down, right? Everybody was doing all sorts of things, Fitbit, you name it, right? There's a ton of them out there. They're not, and the question people are asking, why? Right? Because people don't know what to do with it. I've talked to many, many people, and they kind of say, yeah, I looked at it. I did my 10,000 steps today. Aren't I healthy? That could be totally irrelevant if you crawled the 10,000 steps, right? How did it really affect your cardiovascular system? What is it doing to really change your behavior, and is that important? Maybe 5,000 of a little bit faster steps is better than your 10,000 of your really slow steps, right? But no, people don't know what to do with that. They think it's good. It's all hooked in. There's a lot of stuff on sleep, right? Did I sleep well? Well, yes or no. Are you tossing and turning? But it goes back to what do you do with that information, and how is it then connected to how you're going to change the way you're doing things? So consumers are also taking accountability. So I got this one from Walgreens. And if you go into any Walgreens, CVS, pick your favorite, right now you're starting to see clinics. And so how many people got, if you got a flu shot, from your doctor versus going into a clinic someplace? Right? I went to CVS because it was just quicker. To get a doctor's appointment is just too burdensome to do that. And it's fully, they take insurance, so now they're starting to handle your basics. For any of you who have kids, right, conjunctivitis, pink eye. All of us that have been parents can diagnose that within seconds, right? And so can anybody else, and they just get an antibiotic and you move on. There's things like strep throat, very simple, common things. Now you're going to start to see through Walgreens and CVS and others. They're going to start to become a piece of that primary care physician. But then what happens to the primary care physician? Do they now have to do the harder stuff, right, which is really not where they make their money? So it is going to be pretty interesting. And then what happens to the data that you've just given to Walgreens? How is that going to connect to your primary care physician? And what happens, right? So all that stuff isn't connecting. And so while it really looks convenient, when you go into the hospital or have something that goes on, how are you going to bring all that together in order to really figure out what's going on? And then healthcare and politics. I just happened to take the current page off of the Economist, right? I just said, okay, fine, let me see what today's thing is, and I just did a screen scrape. So the right to die, that's a really interesting one, right? And I've read a lot of books, and there's one on what do you do sort of at end of life. And I think that's more and more going to become something we're going to have to struggle with, because how do you help people produce a dignified life, end of life? My mom has Alzheimer's, and I can kind of see what happens, so I guess it's probably close to me to kind of start to think about that. But you know, it's something the company or the countries are starting to deal with. What do we do for that? Medicare, fat loss needed. Medicare, right, interesting program. They really cut that to the bone, and most doctors don't make a lot of money off of Medicare now. How is that going to affect people? You can kind of go through the whole thing. You know, Obamacare, right, still out there. People don't know what to do with it, attack it or not. And even birth control, right? So it's the gamut of things, but that's going to continue in politics and to work through it. And I think this will have an effect, right? Who knows what the next piece is going to be, and it's a global concern. So what do you do about all that? As just a suggestion for your consideration, behavioral lens. And I think a couple of people started to talk about this, and even in the last one. So my thinking is the thing we've got to do that's different in the digital age is engage people in a different way, right? So we always, how do you really think about the person as somebody with a set of healthcare concerns? How do you use the Fitbit and the other devices to trigger them a way to actually change their behavior? So an example that I use too in some of this is I have the iPhone or the iWatch, Apple Watch I think they call it, and it does nudge you to stand up every hour, right? Because sitting's the new smoking. And the first couple of days, I was like, this is the most annoying thing I've ever done, right? Every hour, it's like I'm in the car driving. I can't stand up right now. I'm in the car driving. But it started to at least bring in awareness. I still ignore it. But it brought in awareness that I need to stand up more. And I do try to do that, not always when it tells me to do that. But that's an example of it started to change behavior, right, in a way that was very positive. How do you start to do that with some of the other things, and how do we work through that? I don't know, but that's that consumer engagement and empowerment. How do you really start to nudge people on a daily basis? There's a lot of pieces that are out there. Imagine if you had your watch and you walk into McDonald's and then suddenly it flashes up to say, I see you're at McDonald's, it's okay, but try to go for the salad, you know? Just simple suggestions here, because we actually can do that. And how would that change? So that goes to the interoperability and connectivity. So I talked about, what if you're at Walgreens and did your flu shot? And then you go to the doctor for your annual physical. Probably one of the things they're going to ask you if you go during flu season is, did you have your flu shot? Is that annoying or what? Right? Why don't we really know what's going on with people as they kind of go across all these different activities? And how do we bring that connectivity? And where that really becomes important is in hospitals. So one of the solutions that we're working on is in the area of antimicrobial stewardship. So an antimicrobial stewardship is a big word, but basically means we all know that antibiotics is a huge issue, right? And more bacterial strains are becoming resistant to antibiotics. How do you really figure out what's the right antibiotic to give to somebody? And we're actually repurposing some algorithms that are used in the defense industry to help understand, based on the person's history, what did they come in before? Did you already try this antibiotic? Did it not work last time? Why are they back in? And if you don't have that history, you can't actually figure out what to do for the future. But if you go to different hospitals, you probably don't have that. So how do we really bring that together? The community support is really important. So we're looking at a lot of different things, and we're starting to do some work with Medicare patients. But they're 65 and older. And are they actually going to be the right targets to figure out how to use the digital world, or are we going to have to go to a caregiver? What is the support mechanism that goes with that that's really important, and how do we engage them? Access to information, technology, and medicine is expanding, right? Everybody's doing all sorts of things, and how do we know what the most current thing is and the most current standard of practice? So one of the things that I'm working on in actually Nairobi, in Kenya, is some things around maternal health. And what we're doing there, because we can do work easier sometimes in these emerging markets than we can in the mature markets, is setting standards on maternal health that are actually changing the standards of care in the rest of the world. It's a shame you have to do it all the way in Nairobi, but you do. But we're able to test it and actually start to think about how do we then change the standard of care for women giving birth and then bring it back into the rest of the world. And then remote care. There's a lot of places that are pretty remote in the world, even in the United States. How do we get them access? Telemedicine and other areas. Another project that I'm in, this is probably my most bizarre one, is working with Native American Indians in a place called Eagle Butte, South Dakota. It's the third poorest area in the United States. It's unbelievable. It is beyond the middle of nowhere. The closest city that we go to stay in a hotel is 90 miles. And there is nothing but 3 shrubs between Pierre, South Dakota, and where we are in Eagle Butte. You can't get a doctor there. You can't even get an electrician there, never mind anything else. So how do we actually provide services to those types of communities? There's 10,000 people in that area that don't have service. So this is an example of what starts to happen when you bring data together. So this is a provider portal, it looks good, but the physician is really at a disadvantage now because they have all these points of information. They don't know how to bring it together to help them make decisions. So I think it is our duty to be able to provide things for them in order to make those decisions in a better way. But what's the relevant information that they're going to need? And I think that's the things we're really testing. There's so much out there, but what are the things that really matter? Because not everything is relevant. So how do you bring that information to somebody so they can make quick and easy decisions? The patient, what do they do? So we have, again, a lot of things that are out there, mobile, pick your favorite device. But how do you provide the right information to somebody so they actually change behavior in a way that makes a difference? And that's really important. And that's, I think, something we're still working on, because I'm not sure we have that right. There's been a lot of attempts, a lot of pieces, but I think this is the area, if you can get the consumer and the patient engaged in a way that they care about their health, I think it's going to make a difference. And we've tried all the sorts of things. There's one test that we did, which I thought this was brilliant and would work really well, where we looked at people's health and how they were monitoring their glucose and a couple of other things and a couple other health concerns such as smoking and such. And at the top of the application, we had life expectancy, right? And if you actually change behavior, it would change. I thought that was really compelling to kind of say, well, you're only going to live to, 75 instead of 90 because you haven't changed your behaviors. For some reason, I don't know, it triggered me, but it doesn't actually trigger a lot of people on some of those behavioral changes. And I don't know if it's the horizon of time is too long. And that's what the problem is with a lot of things. So if you think about even diabetes and other things, if you're somebody with pre-diabetes, it might be 10 years to see the effects of that. So how do you kind of help people understand that horizon of time so that they make changes now to prevent something for the future? And our healthcare systems really are not good at that. They're really interested in what happens to you tomorrow. So the path to value creation is really pick a problem to solve and focus. So everybody's focusing on a lot of different things, and there's so much stuff to worry about. So we're really looking at sort of disease and care coordination and how do you go against caregivers. So that's the area of focus for us. It's a big one, but I think that's something that's really important. You have to figure out who your customers are because it matters. Are payers going to be the ones that you're going to go after? You're going to help to support them? Providers, customer or consumers? Sorry, that's patients. Because depending on who's the primary of that, it's going to matter of how you actually design things and bring it together. You have to trigger people at an emotional level to really figure out how can you get them to take care of their health and that it matters, and how they're going to change behavior. You know, if you go talk to behavioral scientists, and I have, they always say it takes at least 40 days to change a behavior. Can you help them make that change from a digital aspect? Obviously, this little thing triggering me every hour to stand up had moderate success. How do you do with some other things that are out there? And then figure out what data you want to manage. So when you get into personal health information, right, it brings a whole lot of regulations along with it. It's probably the things that are most valuable, but you've got to realize what you're stepping into. I work also a lot with the big tech companies, right, trying to help them. And you can see most of them do a lot of work in healthcare, but as soon as it gets near personal health information, they grind to a halt and say, not me, right? Because they know as soon as you enter that space, it becomes very difficult. And I think this is where the partnership of a pharmaceutical or life science with some of the technology companies, the big guys, can actually really make a difference. And I think, final thoughts on some of that. The future is really all about outcomes. It almost doesn't matter how you get there. What matters is what the outcomes are in the real world. So how can you really figure out how to make a difference in that particular area? You know, yes, I am from a pharmaceutical company, but the outcome is not that somebody took a pill twice a day. The outcome is actually their health is improved, they're back into society, and they're doing something that makes a difference. The other thing that I would just say is leverage partners in a network, right? I don't think anybody can solve this alone. I think it's really important to figure out who's really good in this space or who's really good in pieces of it and come together to solve the problem. I personally don't think it's going to be solved by any one particular player. Start with an MVP and grow it, but make sure an eye towards scalability and not just a single pilot that's out there. And finally, healthcare regulations will continue to change. They're going to drive us nuts. They're different by country, they're different by region, and they happen a lot. Get used to it, I guess, and figure out how to plan that in and adjust as we go forward. So that's my whirlwind tour. How did I do? Pretty good on timing. Yep, of that. So compelling.
So you mentioned the patient portal. That's a lot of information on a single patient in one place. So clearly it's a cybersecurity risk if the data is lost, stolen. So that's one of the fears. You're always looking for that perfect electronic health record, and it's going to at some point be on this patient portal. Other than the inherent privacy risk, which is bad enough, where do you see other risks associated with theft of that data or, you know, attacks on that data?
Yeah, so I've thought about this quite a bit. I'm not sure I have a total answer to that. You're right, somebody can steal that data. The question is, out of that data, what's important or needs to be protected? So some of the things that we keep out of patient portals, or at least I would suggest, are things like social security number, right? Anything that has a financial trigger to them, and some of the other components with that. So I think the risks are, what information can people pull out of that to actually have issues with identity theft, right? So that's one of the things. What information is in there that could have risks of discrimination, right? So one of the things that you'll actually see in a lot of the records is that behavioral information and things on AIDS or maybe some of those social diseases actually has to be kept separately, right? Because there could be an implication if somebody were to figure that out or find that out, it could be some of those posts. So I think that you have to do the best you can to protect it. And people have to be educated that needs to be protected so that you don't give your password to everybody to kind of go through there. But that's why I think there has to be a community approach. So if you think about a community and caregivers, you can then allow caregivers to have different access. You can have other people to have different access to it so people don't feel compelled to give their security away to somebody else to give them the full access. So I think those are some of the things we're thinking about in protecting that.
Are there any way to prioritize some of these things? For example, the other day I was reading that 1/3 of the patients who go into the hospital die because of doctor's errors, like 250,000 people per year. Compared to that versus theft of your medical record. Priority-wise, it could happen, but what are the probabilities? So is there a way of putting biggest bang for the buck? I know if as a pharmaceutical company that may not be your primary objective, but is there a way of prioritizing these things?
Absolutely. We prioritize where the money is and where the issues are. So one of the areas that has been prioritized a lot is readmissions in hospitals, right? It's a huge problem, several $billions a year where people are being readmitted when they shouldn't need to be. So there's a lot of things that are out there in the hospitals today to kind of figure out how do you help patients understand their discharge plan for the first 30 days or sometimes longer than that depending on disease so that they don't come back into the hospital. So that is an area that it's huge and that's been prioritized. So there is places that you can see where there's big spend to kind of work through that. And if you look at testing, so a lot of times doctors retest on everything because they didn't have the previous test. So what if they actually had the information, oh, this MRI was done just 2 days ago, I don't think we need to do it again. So part of that is in that data collection. So I think they do know where those specific areas are. And that's why even some of the regulations are starting to change to kind of help incent hospitals to be effective and efficient rather than point of service, which means they actually like you to have readmissions because that's where they make money.
So you mentioned something that has been something that we've been analyzing a lot in our firm, and that's the use of artificial intelligence and analytics, specifically around all the data, right? And obviously Watson is a technology that everyone is talking about with respect to health, but there are others that are emerging. And as tools that can help doctors take a lot of disparate information, even patients, and conduct analysis. What's your perspective on that, and what's the horizon for that in the near term?
So I'd say there's two things. By the way, we're working with Watson quite a bit, and I'll go into that one. So the first one is, do we have big enough data sets? Right? So I talked about consent. Do we have large enough data sets to be able to find what we're looking for? So we're doing a lot of work in oncology, and we've actually bought a lot of data sets. And what we're looking for, are there indicators for you to understand maybe you're heading towards a high risk for any particular cancer that we've never seen before, right? We know the normal ones. So there's already a lot in there, but you need really big data sets, millions, 10 millions, 100 million in order to find some of those things. And how do you get data sets that are that big? And what you're starting to see around data is becoming the new currency, right? Look at IBM and others. They're buying companies. They're not buying companies. They're buying data. We're starting to work, or considering doing some work with IBM in quite a few areas, and what we really use them for is in modeling of disease progression. So we don't really know how certain diseases are going to progress because it's so individual. Is there a way that you can start to develop models and algorithms such that if you put in sort of your personal piece, you can actually start to understand the progression of your disease, which then helps you figure out what standard of care should then be applied to work through it. It's all in the works. I think we're still trying it out, but it's positive, at least it's heading in that direction.
One last question there.
Thank you for the talk. Cecilia Dom from NYIT. I'm an engineering professor, so I wanted to have your point of view in terms of nanotechnology having in healthcare, for example, embedded devices. Does that have any impact on the pharmaceutical company, and what is your point of view on that?
Yeah, so I can only give you a light point of view because I don't have the deep, but we're actually looking at some of that technology absolutely within the company, because if you take something and actually ingest it into your body, what a great way to figure out what the hell's going on, right? So if you look at personalized medicine, which has been talked about for quite a few years, you can only have personalized medicine if you have personalized data and how that really works. What does your metabolism look like? Everybody metabolizes things differently. So it's absolutely in the scope of the things we're looking at. I don't know how mature it is. So there's one thing to come up with that idea. There's another thing of how you actually get regulators to believe that that is something, right? There's a whole regulation hurdle, and I think that'll probably be the biggest one in that one.
Hi, Judy Artashkar. Quick question. Pharma is a heavily regulated industry, and I heard your cool thing about doing some tests in emerging countries. How do you get away with it with other stuff as well? Because it's, I'm assuming it's difficult to do it also.
Yeah, so we are looking at emerging markets, and one of the reasons why they're so attractive is that there's not a lot of baggage, right? Not a lot of legacy within there. and you have to work within the regulations of that country. So we're doing some work in India, and we're doing some work in Africa and some other African countries, and what we say is we're only going to keep it there. So we follow the Kenya regulations. If we decide to take that solution and move it outside of Kenya to other places, then we're bound by those regulations. But if you keep it only within country to kind of test some things out and try it, you just need to comply with the regulations of that particular country. As you kind of move it outside of that, you absolutely need to then follow other regulations. We do, though, have, Merk does have a set of ethics and things along with it, so we probably exceed the regulations of a lot of these emerging markets, but it doesn't always have to be at the same level of, let's say, an FDA inspection and such.
Great.
Yeah, so it's been following.
We're really running late on time here. One quick
One
question.
question.
Hello, I'm Umakant. I have like young entrepreneurs working on the solution for this, and the main concern is what you said. Out of these three questions, the providers, payers, and the subscribers, someone who has lots of data is insurance companies, that's the payers. Is there a possibility that payers can be connected to the technology, or the startups who can help them get the data, and they can have the connection, they can create the technology to do that?
So I can give you kind of my perspectives on that. And having worked across all three of those areas, I think everybody's interested in talking to everybody. The problem that you'll have potentially with some of the providers is that everybody's coming knocking on their door. So they're going to want to figure out who has something that's really competitive and new and that can scale, right? Because they can't pilot to death. So as a new entrepreneur in some of the venture work that I've seen in there, and at least in talking to them, they absolutely want to do that, but the question is, how do they look at their investments and kind of put it across? Does that make sense? Is that answering your question?
What I mean to say that payers have most of the data. Payers, the insurance companies, can't they be connected to technology companies and create something out of it? That data?
They could if they consent. Well, first of all, the people have to consent to that data being done that way, and that's not generally the way we do consent. So the question is, who owns the data? Is it the person or the healthcare system? If it's the healthcare system, they probably want to keep it because they see value in doing it. So the whole economics of that is just starting to change. But I think that's one of the issues, and that's why I went back to consent. You will need, my speculation, you will need to consent your data to be used for the greater good of research and put it into a larger pool in order to make that happen.
Great. Thank you very much, Michelle. It's a great, insightful keynote, and thanks for taking the time out from busy schedule to share your insights and wisdom with everybody here. Thanks to everyone here, of course, for attending. And also I want to acknowledge HCL and TCG Digital for being the sponsors, Women's Fair Foundation and SimWomen as our supporting partners. I hope you have been tweeting #EmpoweringBeyond, and this is part of our series of events that we host throughout the year in different cities, and we might be hosting another one later this year in New York in September. And I also want to acknowledge another event that we are co-chairing later this month called the Wall Street Tech Summit. It's going to be on May 24th at the Bohemian National Hall. Dan Goodstein there from the Outsourcing Institute, they are the organizers, so hope to maybe see some of you there. Again, thank you everybody for being here, and now let's all go and have some wine and cocktail. Thank you again.